The final part for diabetes is treatment and management. Treatment includes four aspects, of which are lifestyle modification, medical nutrition therapy, physical activity, and pharmacological treatments. In lifestyle medication, we have to advise patients to change their dietary habits, engage in physical activity, achieve a desired BMI, and promote cessation of smoking. In the context of medical nutrition therapy, it should be individualized, recommend a weight loss of at least 5 to 10% for all overweight and obese individuals, advise patients to be on a calorie restricted diet, which will help in weight loss and will have to be modified based on individual responses. Routine supplementation with antioxidants and vitamins is not recommended, and alcohol is best avoided. The third activity falling under management is physical activity, and we should recommend patients to incorporate a mixture of aerobic, resistance training, and muscle strengthening activities. Encourage patients to engage in moderate intensity aerobic physical activity at least 150 minutes per week. Example, brisk walk for 30 minutes a day for 5 days a week. We have to exercise caution in patients with proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy, uncontrolled hypertension, or severe cardiovascular disease, as they should take advice from medical professionals before embarking on resistance training. For those who are unable to walk, that is, open ulcers, foot injuries, peripheral neuropathy, or osteoarthritis, non-weight bearing exercises. Example, upper limb exercises, lower limb exercises in seated positions are suggested. In pharmacological treatment, metformin is the first line oral therapy unless contraindicated, and metformin along with lifestyle modification is the preferred choice. If the fasting plasma glucose is over 200 milligrams per deciliter at diagnosis, consider starting with two drugs. In the presence of severe hyperglycemia over 300 milligrams per deciliter, consider referring to a specialist clinic. Refer to a specialist clinic if patient develops severe symptoms or complications as in, and is in need of insulin therapy. Early combination therapy is preferred than prolonged monotherapy in achieving glycemic targets. As you can see, for lowering glucose in type 2, an algorithm has been prepared. At diagnosis, we advocate lifestyle modification with or without metformin. If metformin is not tolerated or contraindicated, sulfonylureas, DPP4 inhibitor, GLP-1 receptor agonist, or acarbose can be used as first-line medication. Review patient in 3 months and add a second agent, sulfonylurea, if poor glycemic targets. Sulfonylurea, the preferred second choice due to cost and an absence of robust data on superiority of other agents. 3 months later, review the patient again, and if poor glycemic control, refer to the specialist for insulin regimens with multiple daily doses. We have annexed the oral hypoglycemics that could be used with its dosages, advantages, and disadvantages. In the case of insulin in diabetic patients management, initiation should be done at the specialist clinic. Please adhere to the dose adjustment advices given by the specialist clinic once referred back. Goals should be individualized based on duration of diabetes, age, other comorbid conditions, known cardiovascular disease, or advanced microvascular complications. Hypoglycemia and an unawareness and individual patient concerns. Treatment goals also depend on level of HbA1c level, 6.5%, 7%, or 8%. Also need to assess if patient is new onset diabetes, advanced stage, young age, multiple comorbidities. Well motivated patients and if patients with no other comorbidities. In this slide, we look at the glycemic targets. HbA1c should be 7%. Preprandial capillary plasma glucose should be 80 to 130 milligrams per deciliter. Peak postprandial capillary plasma glucose should be less than 180 milligrams per deciliter. When we do refer a patient to a specialist clinic in instances of complications such as diabetic retinopathy, foot disease, or diabetic nephropathy, or if the patient presents with two consecutive fasting blood glucose greater than 7.2 millimoles per liter, despite good compliance with lifestyle modification and drug therapy with maximum tolerated doses of metformin and sulfonylureas, diabetes mellitus with recent deterioration of vision or no eye examination in past 2 years, persistently raised blood pressure greater than or equal to 140 by 90 for any patient in spite of optimum treatment with the combination of three drugs, including a diuretic. We also should refer diabetic patients to specialist clinic if they are present with total cholesterol greater than or equal to 7 millimoles per liter. In individuals less than 35 years, if they have known heart disease, stroke, transient ischemic attack, peripheral vascular disease, or kidney disease, who are not being allowed up by a specialist clinic in order to obtain a plan of management which can be continued at the primary level. We also refer in order to evaluate additional symptoms like angina, shortness of breath on exertion, and an intermittent claudication. We also refer for management of comorbidities. When patient is referred back by the specialist clinic, continue the management with the recommendation.